for inviting me to this conference. I've been asked to talk about neonatal hypoglycemia. I just want to say that this is a huge topic, but I'm going to focus on a few aspects of the neonatal hypoglycemia. Firstly, I have nothing to declare. What I want to do first was to give you an overview of glucose physiology, explain how normal blood glucose levels are maintained, explain the key role of the hormones insulin and the counter-regulatory hormones. I will then go through some of the causes of neonatal hypoglycemia. And the most important thing is I want to show you some novel causes of neonatal hypoglycemia that have been described in the last few years. Unfortunately, I will not be able to cover every aspect of neonatal hypoglycemia. That's impossible in the time that I've been allocated. So let's firstly start with some introduction. So remember that neonatal hypoglycemia is very common. Each one of you that are on this conference will probably see either a baby or a child with hypoglycemia. Please remember this is a biochemical finding. It's not a diagnosis. You need to actually try and find out what is the underlying biochemical or molecular diagnosis. It's important now to interpret the blood glucose concentration in the context of the clinical picture you're seeing and the intermediate metabolites, which I'll explain during the talk. So let's firstly look at what is normal blood glucose concentration. Apart from the first few days of life, your normal fasting blood glucose concentration is kept within a narrow range around 3.5 to 5 millimoles per liter. Now, if you do continuous glucose monitoring, you'll see that blood glucose levels occasionally may flicker below 3.5 or above 5.5, but for 95% or 98% of the time, your blood glucose levels will be maintained within the above range. I'm going to show you there are some intricate control mechanisms that are in place which maintain the blood glucose concentration within this narrow range. So glucose is produced from three main sources. This is glucose from food that you ingest, then glucose made from glycogenolysis, the breakdown of stored glycogen, and gluconeogenesis. This is the formation of glucose from non-carbohydrate sources. And the key hormones involved in glucose production are growth hormone, cortisol, glucagon, and adrenaline, noradrenaline. On the other side, glucose utilization, every tissue utilizes glucose at different rates. And insulin is a key hormone which controls glucose utilization. Just to give you an example, within the brain, certain regions of the brain utilize glucose at different rates depending on the activity of the brain areas. So the word glycogenolysis, like I said, is the breakdown of stored glycogen from the liver and usually occurs 2 to 3 hours after fasting. The word gluconeogenesis means the formation of glucose from precursors such as lactate, pyruvate, some of the amino acids, glycerol. And this used to occur mostly in the liver, but there's no evidence in humans and in animal studies that the kidney also plays an important role in gluconeogenesis. The other most important thing to understand is what happens during fasting. Once you understand the biochemical changes that take place in fasting, you'll understand some of the mechanisms of hypoglycemia, which I'll explain. The first and foremost thing is that the pancreatic beta cells, they reduce the insulin secretion to the minimum when your blood glucose concentration drops to around 4 millimoles per liter. When that happens, that allows the hormones such as glucagon and adrenaline to be secreted, and then come cortisol and growth hormones. So you can see there's a particular hierarchy in the way these counter-regulatory hormones are produced. And these counter-regulatory hormones like glucagon, adrenaline, growth hormone, and cortisol, they antagonize insulin and raise your blood glucose concentration. This is a very simple diagram just showing you the changes in the metabolites and the hormones that occur in response to fasting. So this is time here in fasting. And this is a relative change. So insulin comes down, glucagon levels start going up. You can see liver glycogen being depleted. The most important thing is fatty acids are released from fat and they're converted into ketone bodies. And it's very important to remember that ketone bodies are an alternative fuel for the different organs, especially for the brain to use. Now, it's very important to understand that there are many different symptoms of hypoglycemia. I've just put up a few of the symptoms there, but you can have a baby that's just poorly feeding to a baby that suddenly goes into coma. And this is the extreme sort of symptoms of hypoglycemia. So the key message on this slide is that any baby with any symptom must have their blood glucose concentration checked. I've already mentioned the role of these hormones. So these hormones, the counter-regulatory hormones, act against insulin. And they play a very important sort of defense mechanism in preventing hypoglycemia. For practical purposes, insulin is the only hormone that lowers blood glucose concentration. There are a few rare conditions in adults where IGF-1 and IGF big tumors and IGF two tumors can also cause hypoglycemia. But for practical purposes, insulin is the only hormone that can lower your blood glucose concentration. Now let's go to the neonatal period and let's look at some of the metabolic and endocrine changes that take place just after birth. It's very important to understand this is normal physiology here. So this is just birth and time out, just a few hours after birth. And this is a relative change in the blood glucose concentration. You can see that within the few hours after birth, the blood glucose level drops down, even around to 2.4, 2.5 millimoles per liter, and then stabilizes. And it's very important to remember this is normal. And this can only happen if you have enough glycogen stores in the body, if you have these processes that I explained earlier on, the ability to break down fats, the ability to make ketone bodies, and all the counter-regulatory hormones in place. So remember, this can only happen in a normal term healthy baby without any other risk factor for hypoglycemia. Just a few differences between bottle-fed and breastfed babies. Just remember that breastfed babies have slightly higher ketone body response in response to feeding. And full-term infants are functionally metabolically programmed to make this typical transition from intrauterine existence to an extrauterine existence. And if anything goes wrong in any of the processes that I've explained, or if these processes are incomplete or not developed properly, then of course you're going to get hypoglycemia. And this is typically, for example, in the premature or the IUGR baby. Now, currently term healthy babies do not need any routine monitoring. However, please remember for all the junior doctors that are listening, if there's any symptoms suggestive of hypoglycemia, you must measure the blood glucose concentration. Now, this slide just highlighting some of the risk factors for babies with preterm and IUGR, why they may be at risk of hypoglycemia. Now, these babies have, for example, reduced fat and glycogen stores, they have a high brain to body weight ratio, they have dysregulated insulin secretion, the enzymes that allow you to release glucose are not fully developed, the processes by which make ketone bodies are not completely developed. And of course, the counter-regulatory hormones that I explained earlier on are not also developed appropriately. Now I'm going to try and summarize for you in a simple cut, in a simple slide, the main causes of hypoglycemia that you might see in neonates. So the first mechanism is too much insulin. Now this is called hyperinsulinic hypoglycemia. And there are multiple different causes of hyperinsulinism. And I've just summarized some of these here. These, for example, the infant of a diabetic mother, this is transient hyperinsulinism. These are some of the genetic causes I'll touch on later. So too much insulin, and of course, there are a large number of syndromes I'll come back to in a minute. Now, deficiencies of hormones, for example, growth hormone, ACTH, and cortisol. The defects I explained to you in the mechanisms by which you release stored glycogen. These are the glycogen storage disorders listed there. Defects in the ability to make glucose from those non-carbohydrate sources that I showed you, and these are the enzymes involved in the liver. Defects in the ability to break down fatty acids, these are fat oxidation disorders. Defects in carnitine. Carnitine is an important metabolite that brings fatty acids into the tissues for metabolism. Defects in the ability to make ketone bodies or utilize ketone bodies are cause of hypoglycemia. And there are a large number of metabolic conditions that present with hypoglycemia. So these are the common causes of hypoglycemia that you probably have come across already in babies with different forms of hypoglycemia. Now I'm just going to give you a bit of detail on the hyperinsulinic hypoglycemia. Typically, the transient form occurs in babies with IUGR, the infant of a diabetic mother, and some babies with perinatal asphyxia. Now the word transient usually means a few days, but there are some forms of this condition can last for longer periods of time, and occasionally babies may need treatment with diazoxide. There are a large number of syndromes that present with hyperinsulinic hypoglycemia. The most common one that you will come across is Beckman-Viderman syndrome, but in the next slide I'll show you there are now new syndromes associated with this. And there are now a large number of congenital forms of hyperinsulinic hypoglycemia. So this is just a summary slide showing you the different syndromes. Like I said, BWS is the most common one, but all these other syndromes listed there can present with hyperinsulinic hypoglycemia. And we recently described a novel disorder, polycystic kidneys, with hyperinsulinic hypoglycemia in a large number of families. Now I'm just going to summarize the genetic causes of hyperinsulinic hypoglycemia. So these are the current known genetic causes of hyperinsulinic hypoglycemia. And I won't be able to go through all of these, but just to show you that these two genes cause the most severe forms of hyperinsulinism. And children with abnormalities in these two genes may need a near total pancreatectomy. All these other ones usually respond to diazoxide therapy. This one may be associated with a high ammonia level and protein sensitivity, as might this one as well. This one may be associated with a history of diabetes in the family. And this one usually occurs in adolescence. It hasn't been described in newborns. This causes exercise-induced hypoglycemia. So this is the summary of the congenital forms of hyperinsulinic hypoglycemia. Now, just going back to the other causes, just remember that growth hormone and cortisol deficiency typically can lead to hypoglycemia, as can ACTH deficiency. If you read the literature, glucagon has been listed as a cause of hypoglycemia, but so far no human disease has been described due to glucagon deficiency. It's mostly in animal models have been described. And if you see this sort of thing, this sort of appearance of the genitalia with hypoglycemia, this usually suggests some sort of congenital adrenal hyperplasia. If you see this sort of thing, very, very important to think of midline lesions. So in this case, there's a midline lesion associated with this appearance. And this is where you can save a life by giving hydrocortisone. So these patients may have ACTH, growth hormone, or cortisol deficiency as a cause of hypoglycemia. Now, I'm just going to list for you the common metabolic causes. There are a very large number of metabolic causes, and these are some of the common ones that you might come across. So remember that you will pick up abnormalities in either your blood gas, your electrolytes, your organic acids, amino acids. So somewhere along the line, you'll have clues as to the mechanism of the underlying metabolic disorder for hypoglycemia. So what I want to do for the next few minutes is just tell you some of the novel causes of neonatal hypoglycemia that we've described in the last few years. So I want to show you a new mechanism of hypoglycemia, which looks like hyperinsulinic hypoglycemia, but you will not detect any insulin in the blood or C-peptide for that matter. I'm going to take you to the clinical history of 3 patients. So the first patient was born at 4.5 kilos, started having hypoglycemia after birth. Then as we followed the patient up, he developed hemihypertrophy at 1 year of age and a bit of mild motor delay. The second patient, very similar, you can see quite large birth weight. Again, exactly the same picture in terms of hypoglycemia. And again, hemihypertrophy. The third child was 3.4 kilos, is exactly the same in terms of hypoglycemia soon after birth and mild left-sided hemihypertrophy later on in life. Now I'm just going to list here the investigations we did. So this is patient 1, patient 2, patient 3. This is the blood glucose level. You can see insulin is undetectable in every occasion. Proinsulin undetectable. C-peptide was also undetectable. I want to show you that the ketone bodies were undetectable and fatty acids were very, very low. So this suggests that there is insulin action, but we cannot actually measure any insulin. These are your branch chain amino acids. They're usually low in patients where there is insulin around, insulin action, and again, they were low. These patients were given an injection of glucagon to see if there was stored glycogen, and this typically, you can see that these patients had a very good response, suggesting there's stored glycogen in the liver, which typically occurs in patients with hyperinsulinism. And this is a very busy slide, but just the key message is here, these children had multiple other investigations. No other cause for the hypoglycemia was found. So no metabolic cause, no syndrome, no Beckwith-Whitman syndrome, nothing in terms of the IGF component axis was found as well. So we have so this is just showing you the sort of appearance of these children later on. You can see that each one of them has a gastrostomy in situ. And that's because they needed continuous feeds to maintain normal blood glucose concentrations. And you can see the mild hemihypertrophy in each of them, and possibly the expression of space that you might notice on the slide. And this is just showing you that they gained significant weight because of the fact that they were being fed continuously to maintain normal blood glucose concentrations. So these patients had no response to diazoxide, no response to octreotide. Some of them were even given growth hormone, but no response. And glucagon, we only used it as a sort of diagnostic tool. And the only way the blood glucose levels were maintained because these patients were given continuous feeding overnight through the gastrostomy. So we have a syndrome here. We have 3 patients with a very unusual syndrome of post-feeding hypoglycemia with undetectable insulin, although we can see that there is biochemical action of insulin around, but we cannot pick up any insulin. They all have a bit of hemihypertrophy, and of course they became obese because of the continuous feeding. So this was this was our hypothesis. We looked for mutations in the insulin signaling pathway downstream of insulin. We even took tissue samples of these patients and looked at the insulin signaling receptor itself and downstream. We did not find anything. We even looked at the signaling pathway for IGF-1 and IGF-2. We did not find anything. So this is just, again, summarizing the 2 or 3 years of work that we did on these patients. And just to show you, there was nothing along the insulin signaling pathway, the downstream of the insulin receptor. And to cut a very long story short, all these patients underwent exome sequencing. And interestingly, we found a mutation in only one gene, which is called the AKT2. Mosaicism was present in one child, but the other 2 children had autosomal dominant mutations. And this gene, this mutation is conserved, as you can see very nicely, in the different species here. So I'm going to show you the mutation was present in this gene here. It's called the AKT2. And AKT2 regulates blood glucose levels by controlling GLUT2. It affects the liver by suppressing gluconeogenesis, and also somehow by secondary factors controls lipogenesis. So what's happening in these children is that this is constitutively activated. So regardless of what's happening upstream here, you have constitutive activation of the AKT2. So you're suppressing gluconeogenesis, you're suppressing lipogenesis, and you're telling the tissues to take up glucose so that you're leading to hypoglycemia. So this was a novel cause of hypoketotic hypoglycemia. Now I'm going to show you some other patients again who have another cause of hypoketotic hypoinsuliniemic hypoglycemia. So again, these are 3 patients. I've summarized very briefly their clinical characteristics here. This is the birth weight of the children, birth length. And interestingly, these children all of them had like an overgrowth syndrome. They have megalencephaly, they have Arnold-Chiari malformation, and sort of polygyria of the brain, and severe developmental delay, mild developmental delay present, and some of these additional features that we found in these patients. So these are just showing you the clinical aspects of these patients. For example, patient 1 here had macrocephaly. Patient B here had syndactyly. So just highlighting some of the clinical aspects that you might find on these patients. I want to show you now the biochemistry. So again, this is the biochemistry in these patients. So investigated at slightly some was younger age, some a little bit later. So you can see the blood glucose concentration here. Again, insulin undetectable, C-peptide very low. But again, if you look at the ketone bodies and fatty acids, you can see the action of insulin, but no insulin present at all in the blood. You can see ketones are negative in the urine, and they all had a very positive glucagon response. So again, suggesting that this is hyperinsulinism, but no insulin was detectable in the blood. So what's the biochemical diagnosis in these patients? So the biochemical picture looks like hypoketotic, hypoinsuliniemic hypoglycemia. So what's the cause? Could this be a fat oxidation disorder? Very unlikely. Could this be a ketone body synthesis disorder? Unlikely. Could these patients also have an activating mutation in the AKT2 gene? We looked for mutations in the AKT2 gene and we found no mutations. Or are we dealing with something completely new here? Again, to cut a very long story short, these patients underwent exome sequencing, and we found mutations in another gene downstream of the insulin receptor activation. And this is called the P13 kinase, and I'll show you what P13 kinase is. So these were the mutations, Sanger sequence showing de novo mutations in one of the components of the PK3 gene here. And these are the mutations, and you can see a schematic illustrating the exact sites of the mutations located in P13 kinase. So what is P13 kinase? So again, this is your insulin receptor here, insulin signaling at P13 kinase. It's here. It's just above the AKT2 genes that I described for you. Now, mutations in these genes lead to, again, activation of the pathway here. So in our case, we get hypoglycemia because we activate this pathway. AKT2 gets activated, causing hypoglycemia and the effects that I showed you earlier on. So the molecular mechanism of the hypoglycemia, we think that the P13 kinase mutation is acting upstream of the AKT2 and preventing or activating the AKT2 and preventing the release of fats and glucose from different tissues and allowing tissues to suck glucose up. But it may well be suppressing glycogen breakdown and gluconeogenesis as well. So this is just showing you the mechanism of what might be going on. So here we're looking at the AKT2 phosphorylation downstream of P13 kinase. This is your control. This is your control. And here you can see that in the patients with the mutation, AKT2 is activated here. And again, you can see here as well. So there is
5 minutes more.
Yeah, I'm going to finish in a few minutes. There's activation of the AKT2 downstream of the P13K. The most important thing I showed you this is because there's now potential therapy, because remember that these patients with mutations in the genes downstream of the insulin receptor will not respond to diazoxide, will not respond to any of the medications I showed you, but we were able to show that these patients may respond to a drug called Sirolimus. Some of you will know that these are mTOR inhibitors, for example, Tacrolimus, some of you may have heard of. So when we subjected these cells to Sirolimus, we were able to reduce the activation of the AKT molecule, suggesting that Sirolimus may work in these patients. And in fact, just more recently now, there's been a publication where Sirolimus has actually been given to a patient with a P13 kinase mutation, and those patients improved in their blood glucose concentrations. So I just want to summarize. I hope I've shown you in a very short talk that hypoglycemia is common, especially in the newborn period. Think of hypoglycemia in the context of the clinical scenario. We no longer define hypoglycemia by number. Hypoglycemia is defined by the clinical scenario and the biochemical findings. Please think about the underlying mechanism. Like I said, hypoglycemia is not a diagnosis, it's a biochemical abnormality. You need to decipher what is the underlying molecular and biochemical diagnosis. And I hope I've shown you that just understanding a few patients with rare forms of hypoglycemia can give you new insights into the mechanisms of how insulin signaling takes place. And the most important thing I wanted to show you was that studying these patients has given us new insights into new therapies for some of these rare forms of hypoglycemia. This is our new state-of-the-art children's hospital in Doha, Sidra. You're all very welcome to come along and visit us at any time. Thank you so much.
Thank you very much. Thank you very much for a wonderful talk. There are any questions from the hall? So I would like to ask one question, because you had shown that the insulin levels in these babies was like less than 7, which would still mean that there was some insulin. And what I understand and I know is that if any time a baby is having hypoglycemia, so even a small amount of insulin, if you detect, would come to a category of hyperinsulinism. So how here we said insulin is normal? I couldn't understand that.
That's because your lab uses a different reference range. Hello, can you hear me?
Yeah.
Our reference range was less than 7. Your lab has a different reference range. That's why every lab has a different reference range. But it wasn't just insulin. The C-peptide was also undetectable, which is a more potent marker of insulin action.
Oh, so it was undetectable. Okay,
yes.
Because in your table, it was showing less than 7, so which never...
No, what I'm saying, your lab has a different reference range. That reference range was our lab, less than 7.
Okay, got it. Thank you for clarifying. People were wondering if it could be Beckwith-Whitman syndrome, which I don't think so was, but could you explain why? Yeah,
so basically the only thing we can't work out with those patients is why they have a bit of hemihypertrophy. We're not sure of the mechanism of hemihypertrophy. It could be that there's mosaic distribution of that mutation, but they did not have Beckwith-Whitman syndrome. We excluded Beckwith-Whitman syndrome right at the beginning of those patients.
Okay.
Beckwith-Whitman syndrome have hyperinsulinic hypoglycemia. This was hypoinsulinic hypoglycemia.
Yeah. And how frequent are you using octreotide in lieu of hypoglycemia in children less than 2 years of age?
So basically, octreotide has 2 purposes. You can use it in the neonatal period for hyperinsulinic hypoglycemia. You can use it, usually a few weeks after birth, as long as you monitor. And then there's octreotide for long term. You can use it for long term. For example, you can use like 4 weekly injections of octreotide for long term management of hyperinsulinic hypoglycemia.
Was this an autosomal recessive disease? I don't think so. Was it?
Dominant.
Yeah. Another question is ketotic hypoglycemia, differential diagnosis apart from starvation.
So basically, for example, in any, for example, disorders of growth hormone deficiency or cortisol deficiency, those can easily present with ketotic hypoglycemia. So there's a large category of disorders that present with ketotic hypoglycemia. The only thing that doesn't present is either hyperinsulinism or, for example, fat oxidation disorders or ketone body synthesis disorders. Otherwise, most of the other disorders present with ketotic hypoglycemia.
Yeah.